Good evening. I'm Rotaractor Sandhini Vijayaratna from the Rotaract Club of Faculty of Medicine, University of Colombo. And welcome to COVID Talks, which is the first phase of the project Break the Outbreak, initiated by the Rotaract Club of our faculty. So we actually initiated this project in order to make our fellow Rotaract clubs aware of the things that should be taken into consideration when carrying out projects during this pandemic. But then we decided to extend this furthermore and include university students, members from other clubs, and people from all around the country. So today, in order to shed some light on this matter that has managed to bring the whole world to its knees, we have a panel of 5 well-renowned guest speakers. And I would like Sanidhi to introduce our guest speakers to the audience. Sanidhi?
Thank you, Sandhini. In our esteemed panel today, we have Dr. Ishara Prematilaka, lecturer of the Department of Microbiology, Faculty of Medicine, University of Colombo. Professor Manoj Veerasinghe, Vice President of the Sri Lanka Medical Association and the Head of Department of Community Medicine at the Faculty of Medicine, University of Colombo. Dr. Ananda Vijayavikrama, Consultant Physician at the National Institute of Infectious Diseases of Sri Lanka. Dr. Chathuri Suravira, a Senior Lecturer at the Department of Psychiatry at the Faculty of Medicine, University of Colombo. And lastly, Dr. Manuja Pereira, a Senior Lecturer at the Department of Public Health at the Faculty of Medicine, University of Kelaniya. I am honored to welcome all of you to the first phase of the project, Break the Outbreak. Now a little bit about the structure of today's talk. Each talk will last about 15 minutes, after which, for about 5 minutes, all of you will get the chance to ask questions from the relevant speaker. So don't miss out on this opportunity. Remember, after 15 minutes of talk, you get 5 minutes for a Q&A session.
Yes, thank you, Sanidhi. So, like I said before, today we'll be addressing quite a number of topics regarding this pandemic. But before that, we need to have a clear understanding about what a pandemic really is, and maybe a few things about the coronavirus and the disease itself. So in order to clear our doubts about the coronavirus and the current pandemic, I would like to call upon Dr. Ishara Prematilaka, a lecturer from the Department of Microbiology, Faculty of Medicine, University of Colombo. Madam, the platform is all yours.
Okay, thank you very much. I hope you all can hear me.
Yes, madam, we can.
Yes, madam.
Yes, right, okay. So good evening, everyone. And I would like to thank the Rotaract Club of our Faculty of Medicine Colombo for organizing this fantastic job and also for inviting me to address this gathering. So let me share my small presentation. Right, okay. So COVID-19, the disease. As you all know, COVID-19 initially started in China, where in December 2019, there was an outbreak of pneumonia of unknown origin in Wuhan city. So then they tried to isolate the virus or the causative organism which is causing this disease. And then they saw that the causative organism was really a virus which was similar to another virus which caused the SARS epidemic earlier. So then the WHO was informed about this unusual virus, and on February 11, the WHO experts named the disease as COVID-19 and the causative coronavirus as SARS-CoV-2 because, as I said, it had a close relatedness to a previous coronavirus causing a similar disease, SARS infection. So what are coronaviruses? These are small viruses. These are RNA viruses. They are enveloped viruses, and they are also having this glycoprotein spikes around them. As you all can see, the small projections around them. This is an electron micrographic view of the virus. And you can see the spikes. So it's like that the virus is wearing a crown, right? So corona in Latin means a crown. So coronaviruses can cause disease both in animals and humans. And you all may know that even this SARS-2 epidemic might have been originated initially from animals. Most of the infections are mild respiratory infections, and there are many other coronaviruses that can cause mild infection among us, like we may be getting coronavirus infections in our day-to-day life commonly, but all these are mild infections. But however, there are just a few coronaviruses which can cause severe infections, which can cause severe respiratory disease and also death. Two previous similar viruses are the SARS-CoV virus in 2003, as I said, which caused the SARS epidemic, and then in 2012, the MERS coronavirus. But both of these viruses, the epidemics were limited. They never caused pandemics. But this time, we are hit by a very nasty coronavirus, and that is SARS-CoV-2, which is causing this pandemic. So the initial two were SARS-CoV and MERS-CoV, which did not cause a pandemic. And the latest one is SARS-CoV-2, which is responsible for this COVID-19 pandemic. So why has SARS-CoV-2 has caused a pandemic? That is because the SARS-CoV-2, in contrast to previous two relations, it has a high transmission rate. It is very easily transmitted from a person to another person. And what do you mean by a pandemic? You call a disease outbreak as a pandemic when it affects many parts of the world across the continents at the same time. So millions of people are infected, and you can observe so many deaths also. So for SARS-CoV-2, this pandemic, more than 19 million people had been infected, or really more than 19 million cases had been identified, and it has caused more than 700,000 deaths worldwide. So if you want to get latest data about this COVID pandemic at the moment, you can visit this website. This is managed by the Johns Hopkins University, and you can get figures and the latest data about each and every country. So you see the current leaders are the United States and Brazil and India. So the important thing, I think the most important thing when you talk about COVID, it's about its transmission. All of you have to know about this very clearly. So the most important method of transmission is through droplets, respiratory droplets. This is like for most of the other respiratory viruses. When you cough or sneeze onto those respiratory droplets containing the live virus may directly go and lodge on respiratory mucosae, that is on your mouth and nose or even eyes, and then the virus will enter your body and cause infection. The other important method is through contact, which could be direct contact, where you directly touch secretion, infectious secretions of a patient. It may be through handling a patient or when you shake hands, etc. Or else an infected person may touch his own secretions, and then he may touch another inanimate object like a table or a doorknob, or say he may use a toilet or a light switch, a printer, a telephone, something like that. Because most of these patients are asymptomatic, or they are not ill. So they may just shed the virus without even them knowing it, and they may go around different places, right? So when infectious secretions are put on an inanimate surface, then a susceptible person may go and touch that. Then the live virus may contaminate your hand, the susceptible individual's hand. Then if you touch your own mouth or nose or eyes, the live virus may get transmitted into your own respiratory system, and it may replicate and cause the infection, right? So this is the principle for using face masks, social distancing, and I think it describes the importance of hand hygiene, why you need to clean your hands frequently, because all these direct and indirect contact happens through your hands. So if you keep your hands clean, the risk of you getting the infection is much reduced. So the good news is coronaviruses are not very robust viruses. They're not very hardy. They are susceptible. Now, I told you they are enveloped viruses. Because of their lipid envelope, they are susceptible for lipid solvents and soap. So if you wash your hands properly with soap and water, it's very likely that the virus will get killed. And the other effective methods of destroying this virus are, one is 70% alcohol. Of course, now most of the hand rubs, they have 70% alcohol-based hand rubs. And the other ones would be hypochlorite, hydrogen peroxide, and UV radiation. And there are some other methods using heat, which we use in hospitals and laboratory setups. So coming on to clinical features very briefly, because I think clinicians would, Dr. Anand Vijayakam is here, and I hope he would give a better account on the clinical presentations. But anyway, as I told you, most of the patients are asymptomatic. They do not show any symptoms at all. And another good proportion are very mildly symptomatic. And some of them may have just 1 or 2 features out of these. The ones who are having features of infection, they predominantly will have fever, and they will have a persistent dry cough. Some may have a bit of a difficulty in breathing, and they also have this peculiar feature of loss of smell and taste, which is actually more suggestive of COVID-19 infection. So it's usually mild in children, but unfortunately in elderly and patients with other underlying conditions, they are at a higher risk of developing complications, both respiratory and other organ system complications, and death. Death occurs in a relatively smaller percentage, but the problem is now, because huge populations are infected, we are seeing so many deaths because the numbers are large. Although the percentage of death is small, then again I cannot exactly tell you the death rate, because it depends on different factors, how you calculate and different things. Right, coming on to laboratory diagnosis, again now you all have heard about this so much, daily PCR reports, how many positives, etc. So you all know jolly well that the test of choice is polymerase chain reaction, where we detect the genome of the virus, and the sample is nasopharyngeal and throat swabs. Blood tests are not really done. They are not, we still don't have a reliable blood test, but they might come on. However, any test that you do, you have to interpret this carefully, because you can get false positives and false negatives, right? So you do need to correlate the laboratory results with clinical and epidemiological information. Okay, then coming on to prevention and control, again I think Professor Manoj Veerasinghe will also talk about prevention and control under public health aspects. But however, the key things that you should remember in controlling this disease is covering your coughs and sneezes. Now, by wearing a proper face mask, you will cover your coughs and sneezes. And also by not putting tissues everywhere, use tissues everywhere, having a good respiratory etiquette. And also there is evidence that wearing a face mask will protect yourself also from getting the virus. It may also reduce the chance of of yourself getting exposed to the infectious respiratory droplets also. The other very important thing is maintaining social distance or physical distance of at least 1 meter. Now these, I told you, COVID and most of the other respiratory viruses are transmitted through droplets, and these droplets only travel about 3 feet. So if you maintain a safe 1 meter distance from each other at least, now some countries have recommended 2 meter distance, but if you at least maintain 1 meter distance, you're less likely to get exposed to these respiratory droplets. This is true even if you wear face masks. The other very important preventive measure or control measure is hand washing and hand hygiene. Now, this could be done either using soap and water or using a proper alcohol-based hand rub. The important things are that this has to be done frequently after touching any common surface like lifts, using public transport, using any public or common equipment like telephone, light switches at your office or workplace or your institution, anywhere. And it's also very important that you wash your hands either using soap and water or using an alcohol hand rub for an adequate time, that is at least 1 minute, and using the adequate procedure also, right? You need to, now this link gives a video of proper hand washing technique, so you need to clean your hands thoroughly. Otherwise, just putting a bit of alcohol hand rub onto your hands and just rubbing it won't kill the virus. You will just go away with the false sense of security. So that is very important. Lastly, all of us wait eagerly for a proper vaccine. There are several vaccines in the pipeline. Some of them are actually successful, but we are awaiting a proper effective vaccine in future. So the most important, incorrect information and misinformation is more dangerous than the pandemic itself. So it's very important to get correct information by visiting correct, good websites and other resources. So that's all I have to say. And you all have any questions?
Yes, thank you, madam. If anyone has any questions for Dr. Ishara Prematilaka, you can unmute your microphones and ask, or you can type your questions in the chat box.
Any questions? And my cough is not COVID. Okay. Right.
Madam,
Okay.
there's one question.
There's a question.
Yeah.
Is the mask really effective? Okay. That's actually a very good question. Masks are effective. You may get this question because initially the WHO did not recommend mandatory use of masks, right? But then they said it's necessary to use masks. Why is this? Because the masks themselves, especially the ones that people use, people commonly use, the normal surgical masks and the cloth masks, they are not very protective by themselves. But when everybody is using masks, now if an infectious person with respiratory secretions who is coughing and sneezing, if he is wearing a mask, it is less likely that he will shed all these droplets outside, right? It's not like you just going without anything at all. And on the other hand, you also maintain a safe distance. You have social distancing. And at 1 meter, the other person also, the healthy person also wears a mask. So that will further reduce the risk of the healthy person getting the infectious droplets. That's the rationale for using mask. It's not something like that you can wear the mask and hug the other person, right? You have to maintain the distance and everybody should wear mask. Then only it will be effective. So it's absolutely necessary that everyone goes out with a mask. Right. Types of mask used and right. So actually, the most effective type is the N95 type or the KN95, or in the UK, it's FFP3 standard, which does not come here. So all these are effective against aerosols even. That is, they are effective against very small respiratory droplets. So definitely N95 grade is effective against all sorts of droplet infections. But it's not possible and not recommended for the general public to wear all this, because they are generally not handling um, patients, and they should keep their social distancing also. But of course, for healthcare workers and laboratory workers who will be involved in different procedures, they will do cardiopulmonary resuscitation with the patients, and they may do different things with the samples, which may actually generate aerosols. So in that case, they should wear the N95 mask. But it's not absolutely necessary for all of us to wear N95 mask just when you go up, right? But that is the most effective type if you are interested. Is there a concern of viral mutation potentially increasing the... No, actually, now this is, I told you, this is an RNA virus. So yes, the RNA virus, any RNA viruses, they undergo mutation. It's very common. So the virus will change, but I don't think the infectivity is actually increasing because of that. There was a concern, there was a thought that the virulence or the capability of the virus causing death in people is actually reducing with change. So we don't know about that, but of course there are different small, we call them different genotypes of the virus, but we are not really sure whether that is having an impact on the disease burden at the moment. Yeah, at the moment.
Okay. I think that was the last question. Thank you very much, Dr. Ishara Prematilaka. Your
Thank
talk
you
was
very
very
much,
enlightening.
Yes.
Yeah, and I'm sure your answers are very helpful to everyone who is listening now. We are very grateful to you for setting aside time and time from your busy schedule to address us all today. Now, as we could expect, there are several strategies that have to be put into place in a crisis this large. And several strategies became popular due to the media, such as the hammer and dance principle. Today, we have someone here to discuss the implementations Sri Lanka used to help flatten the curve. Without further ado, I'd like to invite Professor Manoj Veerasinghe, the Vice President of SLMA, to help us understand how Sri Lanka is battling against the coronavirus. Over to you, sir.
Okay. Thank you, and good evening to everybody. And thank you for inviting me. I'll try to be brief. I have only about 10-15 minutes. Can I share my screen?
Yes,
Yes,
sir.
sir.
Hope you can see it.
Yes, sir, we can see.
Yeah.
Yes, okay. Just giving bit of information of COVID and public health response across the globe. I think I would take the Sri Lankan example, which is very close to us and would be a better example than anywhere in the world. If you look at what's happening around at this particular moment, I'll just share this slide where you will see how the epidemic in Sri Lanka progressed up to 10 a.m. today. So this is the epidemic curve, or the curve which shows the cases day by day from 11th of March up to 10 a.m. today. Actually, based on the weeks. And if you look at the actual epidemic in our country, you will see it's a very flattened epidemic, or a curve that goes with 2 or 3 peaks, and a peak of 300 on late or middle to late July, which comes to about the highest peak. So what is the basis of this? If I could explain, in most other countries that you have seen from China, then it goes to the Central Europe, Italy, UK, and part of Germany, Iran, and then shifted to the North America, basically US, and to the South America, Brazil, uh, Bolivia, Peru, Panama, and so on. And it has now coming back to the South Asia, and India is now becoming the main target. So if you look at what happened in other countries and what happened in Sri Lanka, this curve explains what exactly happened in this country. We never had a free spread of infection in the country. We only had what we call a cluster epidemic, which we claim in the epidemiological terms as stage 3, where the epidemic could be defined to a given geographical area or specific groups and not spreading across to rest of the country or the rest of the community. So the key issue is, how did we contain this? When countries like Italy, which has very good health status across the globe, and the US, which spends the highest amount of GDP, gross domestic product, on health, it is close to about 17 to 18% a year. And if you look at Brazil, which is fairly a middle income or high middle income country, which is now devastating, where they have so many deaths and over 3 million cases by now. But in Sri Lanka, why we achieved this is something for us to seriously look at. If you look at the case numbers by today 10 a.m., you could see that we had 32 foreigners infected and 939 cases who came from out of the country who got the cases. And if you look at the local cases, it's a very striking feature. You could see the Navy and the contacts, it's 950, and Kandakadu cluster and they are close associates have about 605. And all other clusters have only 330. This gives a very clear picture where was this epidemic actually. If you look at 32 and 939 of imported cases, those are cases which are actually coming from outside the country. Either they were identified or detected at the very beginning or at the quarantine centers. And if you look at the other clusters, these are the people who were actually got infected from the community being part of a given cluster. And you could see two large clusters of Navy and Kandakadu. And if you look at the total number of 2,839, bulk of these, or about 70% or 80% of these, could be accounted for the major two clusters inside the country and those who came from the outside the country, which gives or the proves my point that this did not spread freely across the country, but it was a cluster epidemic. So that has to be very clearly thought about, and that is where our public health system gives some boost to the whole issue. And if you look at the health system across the globe, there are systems where your curative sector, hospitals and treatment sector is powerful. And there are few countries across the globe where your preventive sector is very powerful and relatively good. And I think Sri Lanka belongs to the second category, where the preventive system particularly is more powerful, relatively well organized, and that is where our strength lies. That is why from the very beginning we were very clear that we have to prevent the epidemic reaching stage 4 and not try to treat people when they get the disease and come to the hospital. Just looking at those figures, you will get some idea about how Sri Lankan health system, particularly the preventive system, is organized. And whatever we did in the prevention we did through this. From MOH officers, then there is actually close to about 2,000 PHIs, 5,800 PHMs, and we have a well-established information management system, including for the communicable diseases. So this was the basis of early detection, containment, and treatment of all the cases that we have seen. So within these basic principles, I would just show you few things that we have done. From my understanding, how I see it, we have 6 phases of preventing or controlling this illness in this country. I'll go a bit detail on few points in the next slides, but basically what we did first is prevention of infection reaching the country. That was the initial phase when China and the Wuhan province got the infection. We prevented it reaching the country actually till about mid-March. Although we got the first case on the 27th of January, there was a lapse of 6 weeks till we get the second case and the actual Sri Lankan case. Second one I would put as containing the infection within the overseas returnees. When they come back, how to contain it within them. And third one is what we did within the country of reducing social gathering, mobility of population, and then detection, isolation, and treatment of cases. And the fifth one was the most important thing, as I pointed out earlier, when it leaked into the community from somebody containing the infection within the said geographical or groups. That was the most successful thing that we did compared to any country in the world. And last one, I will put some thoughts later on staggered relaxation of control measures. And if you look at the earliest phase of the disease, starting, I would rather say the 1st of March to about 20th of March, if you look at the quick response from the country, from the health side, and for the rest of the people to contain its reaching to the community. Starting from the National Action Committee setting up, then actually planning for an epidemic within the country, having hospitals ready, then restricting movement or the restricting visas for people who are coming more infected countries, then totally closing down the airport, closing schools, and so on, which really helped us to reduce any transmission freely within the country. So I would rather say our success lied on these 3 weeks of work during the first 3 weeks of March this year. So I go into more detail. If you look at prevention of infection reaching the country, we had good vigilance at airports or ports of entry. As I told you, restrictions of visas, cancellation of in-flight flights, then the closing of the international airport, and we actually, by doing this, we did not get a single case from actually the highest reported countries that reported cases at that time, which is China, South Korea, or Iran. But actually, we got cases from at that time the countries from the Europe, which did not have such high caseload, which is Germany and Italy. And if you look at what we did, as I told you earlier, from the 1st of March, actually, we were very clear to send and ask people to self-quarantine at home. At that time, the institutional quarantine centers manned by the army was not ready. And you could remember there was a couple of protests in certain areas for actually establishing quarantine centers. So there was a bit of a delay of a couple of days. And then we established quarantine centers, and we had good surveillance within the quarantine centers to make sure and to detect people and to send them to treatment. And as I told you, the initial cases that we got were people who could not be quarantined due to few lapses that happened, particularly due to logistic reasons. And if we could have done it at the very beginning, we could not have seen 32 rather clusters in the country that we saw as epidemic is spreading in the community. And if you look at the next steps, these are steps that has been adapted for over century in this country and where else. We are reducing social gathering and mobility of the population. That is exactly what we did from about 14th of March, closing down all the mass gatherings, educational centers, and the island-wide curfew, which restricted mobility. When you are restricting mobility, then you reduce the burden on the transport system, and will be few people coming and using those, then the spread could be minimized. And these actually worked really well in our country compared to many other countries who started those measures very late. But we started very early in the epidemic. And detection and isolation and treatment of cases, these were areas that has been told in media several times, so I am not going into detail. If you look at the case definition, we started the first case definition way back in January 26 was the first case definition came, even before a case was detected in country. And from up that time onwards, based on the context, the case definition for testing was changing, evolving, and now it has evolved to a more broader definition where you could check people even of suspected people in the community. So there was allocating hospitals, tracing of contacts, and contacts under supervision, and this is how we were able to restrict spread of infection across the country in stage 4. So we were able to restrict it to stage 3, which stage 3 is where the Quarantine and Prevention of Ordinance Act that we were enabled to implement most of the illegal things in this country. This ordinance is 123 years old, is 1897, which was one of the oldest quarantine acts in the world. I think after UK, we got the second quarantine act and prevention. And you need to know that this is the same act that we use up to now, even to conduct the present or the general election few days back. So the lockdown phenomenon that you see across certain areas time to time, and relocating more infectious people into institutional centers, and containing the whole epidemic within 32 community clusters. So when you lock down and take them to an institution, then you remove the focus or the agent from that particular community, thereby breaking the transmission. So all this, if you look at from the epidemiological triad that some of you are familiar with, then you could see we are breaking the transmission cycle. That is exactly which was done. And the last one is staggered relaxation of control measures. And I have bit concerns about that. We did bit of work on planning how to relax the control measures. As being in the technical committee of the Ministry of Health on this, actually we prepared a document in mid-April, and some of those were implemented. There were others who came forward with other proposals too. However, what I can tell is that there was staggered relaxation of the movement and the mobility. However, in certain areas it was too fast. And now you could see people need time to adjust. But I am not really sure people got really adjusted to the new normal instead of the normal situation. What we call is new normal is that you cannot go back to the same level of freedom that we had before 11th of March. It's not only here, across the globe. You need to adapt yourself to live with Corona or COVID for at least another 1 year to 1.5 years duration. because till you get immunity, you are not safe. Till the country, at least 70% of the people get immunity, the country is not safe. Anytime you could have a free transmission of disease in the community. There was some discussion on two things which I would like to end by telling those two. One was about vaccine. Yes, I heard that Russia is going to give their grant permission for a vaccine this week, but there is very little data on that. But as far as I understand, there are about 17 to 18 vaccines which are now on trial out of about 200 vaccines that have been developed. But we need to know two things. When a vaccine comes, it has to complete phase 4 or the human trial successfully. Then it has to get registered. Then it has to be manufactured. It has to be scaled up to treat at least 2/3 of the population of a country. So it has to be affordable. And when all these steps are completed, my general understanding, it will take at least 1 to 1.5 years. That when we are really safe and immune. So that time period, we have to adapt and be sure that we adapt to the general precautions that was actually discussed by the earlier presenter too. So that is where we lie at the moment. And if I can just include a few sentences on the general election we concluded, because I was being a member of the technical committee who ran the COVID-free election for about working for about 2.5 months on that. So if you look at how the election process, we were able to have a very COVID-free election booth, which means it can be done. So it can be done if we can do for the general election across the country, this new normal situation can be adapted to any circumstances, any context. There's no doubt about it. The issue is to what extent, as a population, as citizens of the country, we are ready to do that. If we are ready, then the issues are sorted and we can be free of COVID for some time. The last one I want to just highlight is, you need to understand, in couple of weeks time, we definitely have to open the airport for economic purposes. With the airport is open and it's functioning normally, it will not be possible for us to go on this institutional quarantine forever. So that means that there will be a risk of introducing the infection through point of entry to the country. Unless we practice those preventive measures well, there will be issues. So that is where I am going to end. And for further information, if in the medical students, there are many, you could read the College of Physicians journal last month, where I have done written a detailed account of the preventive measures. There's an article that I have done. And apart from that, Sri Lanka Medical Association had 3 symposia on COVID related issues, and all those videoed symposia are there on the SLMA website if anyone want to refer. Okay, thanks. Thank you.
That was a very informative talk, sir. Thank you very much. Is there anyone in the audience that would like to ask Professor Manoj any questions?
You can either type it in the chat box or unmute your microphones and ask if you have any questions. Okay, as there are no questions, I would like to thank Professor Manoj Veerasinghe for joining this session amidst his busy schedule and for sharing with us such a detailed presentation. Thank you very much, sir. We are honored to have you here with us today.
Okay, thank you. Have a good evening.
Yes. So as you all know, the Infectious Disease Hospital in Sri Lanka, along with the Corona Task Force, has played a vital role in narrowing down this disease to a handful of cases, which has actually made our lives much more easier. So I'm pretty sure that most of you here are very curious about how the Corona Task Force functions and how patients who are infected with the coronavirus are being treated in hospitals, and about the challenges the staff members have to face in treating these patients and so on. So to answer all these questions, there's no one better than our IDH consultant physician, Dr. Ananda Vijayvikrama. So over to you, sir.
Thank you, Sandhani. Thank you for inviting me for this webinar. Can I share my screen, please?
Yes, sure.
Can you see it?
Not yet, sir.
Do I have to share, or can you share it from there?
So you have to share. Yeah, we can see it now.
Yeah.
Sir.
Okay, thanks. Right. Yeah, if you look at the history of this, as you know, this the first cases were reported in China, Wuhan province in January. And these are the historical accounts of initial estimates. WHO estimated of a mortality rate of 3.4% as of 3rd of March. In China, it varied from province to province. On average, they had a 2.1% of death rate. And in Wuhan, it was high as 4.9. And then by 20th of February, China said that the increasing mortality rate of 3.8 nationwide with 5.8 in Wuhan. And around that time, there was a study showing a tentative mortality rate of 3%. But the important thing or striking thing with this was the high mortality rate of hospital admitted patients, which amounted to about 15% in China at that time. And people died within 40, most of them died within 14 days of admission to the hospital. The present situation, we know we have 19.8 million cases worldwide with 730,000 deaths as of today. In Sri Lanka, the first patient was reported on 26th of January. That was a Chinese national. And then we had our first local patient on 10th of March. Since then, we had up to now until yesterday, by yesterday, 2,841 cases. And of these, 2,576 patients were discharged and 252 cases are still in the hospitals. And there were 11 deaths. During this process, there was a very strict quarantine process adhered. As Professor Veerasinghe said, we quite actively initiated this quarantine process with the government started this. So initially, from 11th of March, people arriving from Italy, Iran, and South Korea were quarantined. And then for other overseas returnees, were advised to have self-quarantining for 2 weeks. And then these countries had a travel ban from 14th of March. And from 19th of March, the airport was shut down. So we were effectively preventing patients from coming into the country or the infection coming into the country. And that worked quite well. We were able to restrict this. And in addition to this, there were mobility restrictions. In most part of the country since 17th of March, there was total lockdown with intermittent releases, and then police was empowered to maintain lockdown measures, and only essential services were maintained during that period, like other than for some selected services like ports. And then there were measures to deliver food and other essential items, and some group of general public were getting financial allowances due to these restrictions too. Because of this, we were able to contain the illness, and you can see the spread of illness. This shows the total number of cases, and the black line shows the active cases. So you can see the number is going down pretty well, and as of today, and this shows the daily new cases. And by now, we haven't had more than 1 or 2 cases for the last several days. We had several clusters. Initially, we had the Navy cluster, then we had the rehabilitation cluster from Kandakuda, and then, however, the total number was remaining low, and because of these measures, we were able to prevent community spread. So therefore, still the cases are limited to clusters. We had occasional cases coming up in the community, but they were also related to people from these clusters. So therefore, we say that still there is no community spread of this. And the spread of these clusters were controlled with active contact tracing and quarantine. As I said, there were Kandakuda camp and rehabilitation camp, and the Navy camp had 2 outbreaks. And over the last several months, a couple of months, you notice that the mobility restrictions are gradually eased off. And unlike in many other countries, in our country, we decided to admit all the COVID positive cases and quarantine their contacts. We were able to do this because of the limited number of cases. The idea of doing this was one for monitoring of these patients, and then to prevent the spread of these patients by isolating these patients and minimizing the contact of these patients with the general public. And in addition, there was active contact tracing using public health network, and not only that, using the state intelligence services. And then the contacts will be quarantined initially in own houses, and then later when it was realized that sometimes the people were not living in adequate environment to be quarantined, then they were moved to quarantine centers and monitored. And then these contacts were tested in quarantine centers. Initially, we tested them only after 14 days, but later we had an immediate test done, and then 2 weeks later, a test done, and they were discharged from the quarantine center only if they were found to be negative. So a lot of tests had been done. Initially, the test numbers were low because we didn't have many patients. The total number done was around 90 per day from February to March, but then these numbers went up gradually. By middle of April, it reached about 600 tests per day, and then the numbers went up to about 1,500, 1,700 per day during the early May period, and then by July it went up to 2,700 per day. Now again it has come down because naturally, because the case numbers we have is low, so the contact tracing and contact testing is becoming low. However, still there is active screening and testing is going on to detect possible cases from the community, and also the contact tracing is still continuing very much. Because we were admitting all of these patients, these are the patients with symptoms. Initially, you can see the patients shown in yellow are patients with symptomatic patients. Initially, these patients who had symptoms were actually patients who came from abroad, from Italy, then from Middle East, India, And then later we started getting patients from Sri Lanka, and most of they were detected during active contact tracing and testing. And those other patients shown in blue lines, so most of them were asymptomatic or only had very mild symptoms. Most of these patients were in middle age. They were most of them were belonging to 21 to 50, 60 years of age, majority. And majority of these patients were males. This is an analysis of the first 253 patients. So almost 3/4 were males. Which is comparable with other findings in other countries. When you look at symptoms of these patients, the commonest symptoms were the fever and cough, and then some had about 15% had sore throat, another 13% had myalgia, then the 12 had nasal congestion. Initially, we did not actively look for loss of taste or loss of or anosmia. But later, when it was reported from some other countries, we started looking at that, and then later we found to be these are the initial figures. So the actual figures would be higher than this. Because later we were actively looking for these symptoms, and several patients had these symptoms. And actually, some of these patients, the only symptom was either loss of taste or loss of or anosmia. Total number of patients admitted to my hospital during this period was 1,373. This is including the positive and suspected patients. Out of this, 599 were confirmed patients, and most of them were mildly symptomatic patients, and another lot were asymptomatic. Out of these 599 patients, 28 patients were given ICU care. Out of these, 7 patients were mechanically ventilated, and 6 of them died. The last patient survived. We were able to save her after ventilating her for 21 days. So that we consider as an achievement of our dedication of our staff. Initially, we had a lot of challenges. Because of high number of deaths and rapid spread of the disease, naturally there was fear among general public as well as healthcare workers. This was shown not only in our country, but in many other countries, including well-developed countries also. And then to add to that, the disease process or the pathogenesis was unknown, and no proven treatment was available and still not available. And so we are not sure with what to treat. Because of this high number of patients who are getting bad or dying, there are a lot of efforts to produce an increasing number of ventilators available in hospitals. And this is how went up in the UK, the production. In 2019, the average ventilator production was 700 per week. And then by end of March, it went up to 2,000. By end of April, it went up to 7,000 ventilators per week in the US. And in the UK, they formed a Ventilator Challenge UK consortium with the contribution of industrial technology in the engineering business, with aerospace, automotive, and medical sectors coming together to produce and increase the number of ventilators available. However, looking at the bigger picture, with that, there were a lot of trials also started to test medication, to study the pathogenesis of the illness and the symptomatology of the illness. And by these are the trials in the initial 10 weeks of the illness. You can see 382 trials have been started by the first 10 weeks during of this illness. Even though there was no definite treatment available, our expert committee on guideline development decided it was formed by the request of Director General of Health Services, and it consisted of physicians, microbiologists, virologists, and we had about more than 80 meetings during the last 5 months. These are Zoom meetings going on for more than 1.5 to 2 hours Initially, we had almost daily meetings. Now we have lesser number. We are having lesser number of meetings. We decided to recommend hydroxychloroquine to all COVID-19 positive patients initially. This we continue still. We give this to symptomatic patients still. This decision was based on limited available evidence at that time, and we are in the process of reviewing this decision with new evidence coming up. Other antivirals are not recommended and are not used in our country still, and no prophylactic treatment is recommended. And then in addition, this committee made many other guidelines about, for example, about quarantining after exposure to a patient, then the discharge policy, and so on. Looking back, looking at the bigger picture, now I believe what we need is more facilities, is oxygen rather than more ventilators. Probably the commercial aspect also went into play in this. So a lot of advocacy on ventilators are going on. So we believe in our country, ventilators should be supplied for identified places with the view of future ICU development plan. And another important thing is necessary is to reduce the phobia and stigma. These are probably the two main steps which are necessary in improving the clinical care of these patients. So we are using these wards for these patients, open wards for these patients. In our hospital, we have this half-wall wards. We are using these with good ventilation. We haven't had any problems with cross-infection still. These patients are not COVID patients. This was taken before that. But we haven't done any structural modification to these wards to keep these patients. The government took a lot of commendable actions. The President, His Excellency, the President was directly involved in this. And then there were this task force headed by the Director General of Health Services and the Commander of the Army. And there were many other committees headed by, a few other committees headed by key politicians. Then there were several committees at the Ministry of Health. Then the quarantine facilities were handled by Sri Lankan Army. And then there were key decisions, which all these were important for minimizing the number of patients in the country. And the key decisions were the lockdown, the closure of airport, and then the involvement of armed forces and the police, including state intelligence services for contact tracing, and then gradual reopening. The present situation is, as you know, we have very limited number of cases. However, there's complacency among political leaders and general public, which is worrying. And we have an economic crisis, not only in our country, many countries have this, a lot of countries have this due to the present situation, due to closure of business, reduced exports, lack of tourism. So we are in trouble. And then you have seen that over the last couple of weeks, the disease spreading in Australia, which had a well-controlled disease for many months, and now they had to close down several cities and provinces, and we know our neighboring country, it is rapidly spreading. What we have seen when we study this spread, what we notice is there's a rapid spread occurs when the case number exceeds a certain level. So when it exceeds a certain threshold level, then spread just like wildfire. So that is why we have to be of concern. As mentioned previously, there are several methods which we have to adopt in preventing the illness and preventing the spread. The hand washing is the key thing, the proper hand washing, using soap and water, and whenever that is not possible, to use hand sanitizers. Again, as mentioned by the first speaker, it has to be done properly. And then practicing cough etiquettes. Social distancing is very important, especially people have to avoid unnecessary gatherings and maintain distances even when they are in a gathering. Unfortunately, this is not seen at present. Then we have to minimize touching surfaces unnecessarily, because the surfaces can contain the droplets and the virus. And then the good ventilation, good sunlight, prevents the spread of the infection, which are our natural resources. We have to use this. Unfortunately, still a lot of our offices are air conditioned, closed, and that can facilitate the spreading of the illness if we get more patients. Avoiding smoking is very important. Smokers tend to get are more liable to get the infection and also more likely to get complications and dying of the disease. Then the face masks are important, especially if you have to go to a gathering, you have to wear face mask, but wearing that properly is important. In spite of all this knowledge, you can see in the US, they are going to have a motorcycle rally amid this pandemic with 250,000 people are expected to attend without, and they have said the face masks are not required. So that is the unfortunate situation. In the US, unfortunately, our people also, you can see how these people are wearing face masks. In some people, it is in the chin, in some people, it is below the nose, and many people. And the unfortunate thing is, the media is showing these pictures to our general public. So when doctors tell this is the way to wear masks, and media is showing multiple times these things of improper wearing of masks, which message the people to take? This leads to confusion of general public. The challenges are, of course, still in the healthcare workers. The persistent fear is there. So often the personal protective equipment are used unnecessarily. Then we have seen body spraying and unnecessary precautionary measures. And then, as I said earlier, the complacency among public, for which I believe the political leaders and media are largely responsible, leading to public gatherings and non-adherence to physical measures, health measures. So unless we attend to these things, look at these things quite strictly, if we get more patients, the spread will be unavoidable. And if we have more cases, then that can lead to a lot of problems. Thank you.
Thank you, sir. Are there any questions for Dr. Ananda Wijevikrama? There's a question in the chat box. Sir, how do you tell apart an actual drop in the number of cases versus a low detection of cases?
You mean in Sri Lanka?
Yes, I think.
That is because of the restrictions and quarantining, we were able to prevent the spread of the illness. I said, therefore, naturally, the numbers are low. I think somebody has to be tested for COVID.
I suppose.
So at the moment, since we don't have a lot of spread or the numbers are low, even though the testing is continuing, the number of detection is of course low. So
excuse me, sorry, but can everybody mute if you're not asking a question, please? Thank you. You can continue, sir.
Yeah, so the problems can occur when we open up the airport, when we are starting getting tourists and people, expats can come back. And when we are getting those people, then we'll have to intensify testing to detect more cases. And that is where we can get the illness again. In the present context, as long as the country is closed down like this, it is unlikely that this will spread, but we cannot continue like this. We have to open up the country. We have to increase the exports. We need to get some imports, and we have to start tourism. It's a vital industry. So with these things, the risk of spread of the disease is there. That is why these habits have to go into the public mind, and it has to be the second nature of people. So unless that is over and over told to public and make sure that they do it, it will not be a practice. It has to be a practice and habit.
Yes, thank you, sir. There's another question. How effective are cloth masks against coronavirus when comparing to surgical masks?
Surgical masks are better. Surgical masks are effective, better effective than cloth masks. The difference is that the cloth mask you can wash and reuse. The surgical mask you can't. Surgical mask you can wear up to about 6 hours, but and then you have to throw it away. You have to throw it away properly. But cloth mask, if you can wash. So that is the advantage. Since we don't have sort of a large spread, or at the moment, since we don't have community spread in the country, using cloth mask whenever you are going to a gathering is adequate. However, you have to wear it properly. You saw how some leading politicians in the country were wearing these masks, right? And that is shown by the media. At least the media should tell us that these not the like, say, in a film you see when they are showing a smoking scene with smoking or alcohol taking. They say alcohol is bad and smoking is bad. So the media should tell this is not the way to wear a mask or something like that underneath. Otherwise, people don't realize it. So you have to wear it properly if you are wearing a mask. Otherwise, it can be actually worse. If you are not wearing the mask, if you keep it in the chin and wear it again, then you are more likely to get an infection.
Yeah.
It can be dangerous.
Yes. So there's another question. So previously it was recommended that we wash our groceries before using them. Is this action still necessary?
The reason for this was that when you go to a shop, especially groceries, people tend to touch it, and sometimes we touch it. If we don't think it is good, we don't buy it and we keep it again in the shelf. So there's a possibility that the germs are there. So it's a good habit to develop. It's not only not only prevent COVID, but will prevent other illnesses also. So it's a good practice to develop.
Yeah, there's another question. Is this a systemic disease?
Yes, it's a multi-system disease actually. Initially, in China, when this was started, it was thought that it is the pneumonia which causes the problem. But now people have identified it's a multi-system disease affecting more than pneumonia. Now the theory is that it causes thrombosis of microvasculature of lungs, leading to ventilator perfusion mismatch. And that is how patients become hypoxic and eventually die. And later, of course, they get pneumonia also. So that is probably the viral pneumonia plays a part, but maybe more, or at least at the same level, this thrombosis process also plays a part, and that tend to affect the heart. Even there are reports of strokes and myocardial infarction and so on. So it is a multi-system disease.
Yes, there's another question. Sir, with the high number of cases in India, what are the precautions being taken to reduce the inflow of the disease into our country?
The problem is, as you know, there are illegal migrants coming by boats. Now the Navy is trying to prevent that, but how effectively they can do it, I don't know. So we know that even during the wartime, in spite of all the precautions taken by the Navy, still people were coming from India to Sri Lanka and Sri Lanka to India. So they're trying to prevent it, but I don't know whether it can be done 100%. So the risk is there.
Yeah. There's one more question. Sir, what is the target of spraying disinfectants to the ground? We have observed disinfectants being sprayed to the ground around public places like police stations in the past few months.
The simple answer is it's a useless practice. And similarly, body spraying is useless, and also it can be dangerous.
Sir, I have a question. Can I ask it?
Yeah.
Yes.
Sir, you said that you haven't observed any cross infections. So that means you don't need isolation. So is that what you mean?
No. What I mean is the cross infections occur when people are together. So what we do in the hospital is when we identify or when we diagnose a COVID patient, if we have several patients, we cohort them in one ward. So they maybe about 8-10 patients will be in one ward. but they are in open wards. Open wards does not mean they can come out. They have to be inside the ward. When we go into the ward, we wear personal protective equipment, but otherwise in the hospital we wear only a face mask. When we walk on the corridor, so we wear face masks. And actually in this, I showed you the slides. In these wards, these are half wall wards. So we talk to them across the wall, sort of on top of them. It's a half wall thing. So when we go to that place, we don't wear the full PPE. It's not necessary. I think it is important. This good ventilation is important. We haven't had any infection of our health staff, even though we were keeping these patients. And in fact, we think it is a good measure of prevention, keeping them in good well ventilated wards.
Right.
Yes.
Thank you, sir. So another one. So what do you think about the use of dexamethasone? Is it used here?
No, not yet. Well, in a recent trial done in the UK, which is called Recovery Trial, they have tested dexamethasone as one arm. It had been, the preliminary report shows that it is effective in a certain group of patients. The patients who need oxygen and patients who need mechanical ventilation. They haven't still published the full report. So if we get a bad patient, we might also use that, but not routinely. Even their findings does not advocate use of dexamethasone routinely.
Thank you, sir.
So there's one more question in the chat box. Can it also spread via slippers and tires of vehicles when they get contaminated?
Well, if they get contaminated, the theoretical possibility is there, but this does not last long in the environment. So again, we come to the spraying business. I don't think that is necessary. Spraying.
Yes.
Okay. Thank you very much, Dr. Ananda Vijay Vikrama. I'm sure you answered many problems that were in the minds of our viewers. We appreciate greatly the knowledge that you provided us today and the time you set aside to do it. Thank you, sir.
Yeah.
Now we know throughout this pandemic, there have been many changes that have made it difficult for people to handle mentally.